All right, so remind me of the questions on
Okay.
pain.
Um, so the first one I have was just how does movement relate to pain? It seems like lack of variability in a system seems to be associated with the possibility that there's more likelihood of pain.
Hmm.
But it seems like there's never, a way to be sure. So basically, then are we just using probabilities to make our decisions in what we think may likely help reduce pain
Yeah, I mean there is
or may not be beneficial?
so there is pain when it's actually present,
Hmm.
versus pain prevention and injury prevention. And you hear all of these different terms, and I think it's important to separate them out. So when you have the world of injury prevention, then you now have to think about, like, what are you doing with in the absence of pain that might cause pain, right? When you actually have pain, you can use pain as your number one thing to assess, right? Like the provocation of someone's pain becomes its own assessment,
Hmm.
right? Which is very different than thinking about things when pain isn't present. It's like, oh, don't do this or you're going to hurt someone, you're going to cause pain, right? So that, I think that always has to be separated. And when you think of things from a structural standpoint, a lot of times those two worlds become the same thing in people's heads, where it's like, okay, the thing that you would do that maybe causes compression of a joint or would be considered bad form or a loss of postural control would be the same thing that's causing someone's pain. And that's not accurate, right? So
Right.
we want to think differently along those lines. But when somebody actually has pain, now you can really try to discover everything about that pain and the provocation, what brings it on, what makes it better. So you look at it from a subjective standpoint and an objective standpoint. And so I think the subjective standpoint is when you're looking at the life history of that person's pain,
Hmm.
right? And so we can all use our own examples. Like, we really have it. It just might not be like super chronic and super debilitating for every person, but
Yeah.
we all have a history of pain somewhere, which will then lead to will affect our current pain if we have any. So you can think about your own history. I can certainly think about mine. But if you had a history of pain, then that the next time you get pain in that area, it's going to be different than if you would have never had it before,
Hmm.
right? So, and that's subjective, but it is important to understand that every time you have pain, it's a different pain experience,
Hmm.
right? Even if it is in the same general area, and that becomes something to just take into account, right? Like that, it's like the location of pain is not really that objective a lot of times, or it's always in changing. So if we look at like a location and try to correspond it to this objective structural mechanism, it's really two different things,
Hmm.
right? And to look at injury and pain, they're two different things as well,
Yeah.
right? So if you and here's a good example, right? If you had an ACL repair, right?
Yep.
So there's a protocol that you had to go through for your ACL rehab. There were likely times where you were in pain and likely times you weren't in pain, but it wasn't really the pain that dictated where you were in your protocol, where you were in your progress, was it?
No, it
It was
wasn't.
just time.
Yeah.
And it was just, the surgeon's protocol or orders. And that's injury, that's a very specific, you're recovering from surgery, but that is basically like an injury, but it's not necessarily dictated by pain. And
Hmm.
it needs to be done that way because you're trying to protect a tissue. You're not necessarily trying to work in response to pain.
Hmm.
Okay, so that happens a lot when we look at like specific healing patterns. We don't really need to care as much about pain. Like, pain's still important, and pain might be a limiting factor to actually having us move forward with a protocol.
Mhm.
But if somebody doesn't have pain, that doesn't mean we do more than what the tissue is ready to do. Okay. So that would be, to me, like a difference between injury and pain and how you use them. But if you get somebody that's coming in with pain, we don't necessarily need to put it in the injury mindset of like this needs to heal like a ACL would after a repair,
Mhm.
right? So like post surgery, it's all really about repair, much less about pain, right?
Yep.
And pain is important, but it's again, it's not going to be the thing that dictates where you are in a process. But when you're outside of that and you're thinking like pain is the major factor, now we have to use that and we have to really understand the pain behavior objectively by assessing when it comes on during a movement. What can we do? Can we position differently? Can we create certain type of postural cues? Can we create different type of breath cues that change the pain? And we just really want to get a consistent patterning of this pain. And that is separate than what's going on structurally, because we'll never have the two going on at the same time. Like we're not looking in the body and seeing things changing structurally while we're getting this dynamic understanding of how somebody reacts to movement and how their pain responds to movement.
Right.
So there are two different things, but like pain is super valuable to understand. We just don't want to take, okay, I have pain here, I shouldn't do this. Like that should not exist, because then we can't learn about that person's pain that is individual to them, that is individual to that specific experience. So even if they've had a similar pain before, it's automatically going to be different because they have a history of that pain, because it's a threat response to the nervous system. So every time you get a new pain, maybe it's more of a threat, or maybe because you're so used to it, it's less of a threat. But it's definitely a different experience because you've had the experience before.
Right.
Does that make sense?
Yeah.
So that's important to understand all of that history that somebody might have with it, but also appreciate that it is not this objective static thing that an orthopedic diagnosis tries to create.
Mm-hmm.
So that's what we have to be able to separate out.
Right.
And that doesn't mean that an orthopedic diagnosis is useless. It just might not be that useful for a physical therapist that is working with movement, because we aren't really assessing that and we're not going to be using that to create change. Right? We're going to be using their symptom behavior to create change.
Mm-hmm.
And so if somebody doesn't have anything on an image and their symptom behavior says that it hurts to do certain things, we don't just ignore their hurt because there's nothing on an image, and vice versa. Like we really have to take their symptom behavior as the major thing that we're working with and seeing change.
Right.
Right.
That's like the whole thing about pain doesn't necessarily equal damage. Or
right. Yes, I think the term injury and damage can go hand in hand.
Right.
Right. So if there is damage, if there is like a recovery from a surgery where there was a purposeful damage created to repair something that was damaged, right? But you know something is healing. You know there's research on the healing process of that. If something is acute, a lot of times you can follow some literature on a healing process of a tissue. But that has to be, to me, that has to be an acute injury, mm-hmm. not a chronic injury. Like if stuff starts getting several months down the road, we're not really looking at a healing process of an injury. We're looking at a pain that we have to understand the behavior of in response to movement. Right. And to me, that's where I would separate things out. Like if things are really, really acute, like I don't really want to work on that injury. Like I want to allow the healing process to take hold. I want to maybe allow them to move in ways that don't hurt, and I want to just show them that as much as possible. But I don't really want to be poking the bear too much.
Right.
Right. But if things are, more chronic, you kind of have to poke the bear a little bit, and you have to figure out a lot about this person's symptom.
Hmm.
And part of that's going to be the subjective history there, and like what are their beliefs about it, and all that. But then your goal as a therapist, I think, is to be able to separate that out, all of their beliefs, and try to figure things out and make it as objective as possible to their movement. Like, what brings this on for you? Can you describe that to me? And sometimes that's really difficult for people to do, but that's the first goal of a therapist, should be to be able to figure out the with what, not really break down the where as much. Like you'll know about that. Like you'll have a history, a body of norms that will be like, okay, if there's pain here, now I can understand, I can backtrack into the relationships of the body that I know that might be leading to a mechanical stress, a pressure change to that area on a regular basis.
Hmm.
Like you'll want to have that in your head, but without the understanding of the with what, like what brings it on, then you can't really start to break down the movement limitations that they might have around that pain. Right? So I want to know, like, does it hurt sitting? Does it hurt standing? Does it hurt walking? Much more than I want to really think about the structure inside the body.
Right.
At least at first,
Yeah.
at least at first, because that can really open up my assessment much deeper.
Hmm.
And then you can deconstruct the movement that they're having issues with by, going more static, slowing it down, giving them more support, and see, like, when is the very onset of their symptom. Like if it's in a daily function thing, so say walking hurts and it hurts with daily function, then we can break down walking in a way that's more controlled and see if we can provoke that pain in a very controlled way. And now we have a very specific assessment of when this comes on, but we can also see what is natural and unnatural for a person with walking, just by breaking it down and changing it and making it a little bit more specific.
Hmm.
Right.
Right.
So all of that can really give us some information, like, or what do we want to work on? Right. If we just change somebody's gait and just teach them to walk a little bit differently by giving them support, and their pain goes away, or they don't have pain when we do that, then we know, okay, like our goal in the long run, and it might not be quick, is to get them to change the way they walk, to have more options for walking than they currently do now. Because that's typically part of the problem, is that there's a compensation pattern that's gone on for a long period of time, that they don't have any other options except the thing that hurts, or some really, really exaggerated compensation, like, totally not putting any weight on a side or something like that.
Right.
So we want to have some norm that we're trying to see, like, how can they do the norm without pain?
Hmm.
And then if they can't, can we give them a certain amount of assistance to allow them to do the norm without pain? And can we then move them through the continuum to get them to not need the assistance, and to reestablish a norm that they couldn't do before?
Right.
And a lot of times they'll have not had this norm, this movement norm, way before the pain. So it's like the pain is a latent response to this, not having a movement options.
Hmm.
Or at least that's the way to consider it. You don't know that that's true, but that would be a way to consider it, is that, like, you can see now, because they have the pain, that when they walk a certain way, it brings the pain on.
Hmm.
But you would assume that it's not like as soon as the pain came on, that's what changed their gait.
Yeah.
That it was probably there before that.
Before the pain.
Yeah.
Hmm. So then essentially you're trying to just, I guess at a basic level, give people more options in whatever it is that tends to bring on the pain to a certain extent.
Right. Exactly. And more options. And then you do want to have something that, like, a starting point, like a movement relationship in your head.
Right.
That would be optimal. You know what I mean? And it's not perfect. It's just that, like, there's an optimal idea of how you would want to get someone to move. And this is all the other stuff that we would talk about from a standpoint of, hip shifting, hip hinging, squatting. There's not so much like a perfect way to do anything. There's just a relationship to what somebody can't do when they have pain, or sometimes when they have pain and you get them to do that norm, it takes their pain away. Then you start to have like this connection that's saying, okay, like I want them to be able to do that on a more regular basis. So I think all of these models of movement really just give you a better starting point. Like, so you don't have to just be guessing of like, what should I do for this person to make their pain a little bit better with the task that they're having pain with. Mm-hmm. It's the models of movement that we would be able to go to would help us understand these relationships already, to say, let me try this first, because it makes sense to me of how, you know, what a lot of people might be having difficulty with, but also why it might make movement more efficient and decrease stress or decrease load in a very specific area. Mm-hmm. Right. So another way to think about that would be just these models might help you share the load best in your body. Mm-hmm. Right. Share pressures best in your body.
Right.
Right. And oftentimes these compensation strategies they're just not sharing load really well. They're making you not move from certain areas and only move from other areas all the time. So yeah, it comes back to not having as much options for movement, but it also may be that there's just not enough load sharing that can go on with any particular movement either.
Mm-hmm. All right, and so that, to me, seems like a combination between, again, like giving people more options, but then there's also the learning process of helping them learn how to use those options.
Absolutely. Right. And that's
the most common strategy.
And that's why I like to personally, I like to start where people are like most limited from a functional standpoint. I know that term gets is bastardized now.
F-bomb.
So let's not use that term. Let's just say what someone actually is complaining of that matters to them. Mm-hmm. Right? Very few people give a shit about hip extension. Very few people give a shit about like hip rotation, about expansion, compression, stuff like that. Like that matters to us because we can connect it to bigger models and things like that. But very few people are going to complain about that unless they're doing a lot of YouTube surfing and things like that, right? But if someone's going to complain about like, it hurts when I walk, it hurts when I roll in bed, when I sit for too long. So we need to be able to deconstruct what's going on with sitting, what's going on with walking. And then we can have other models in our head that would tie into those bigger movements, right? Mm-hmm. And then we can start to deconstruct, okay, what are the joint ranges of motions that we need or that we would need to be optimal so that people don't compensate in these different positions, right? So that's just it's a deconstruction process. But I think we need to really start from the movement, because a lot of times it's a motor learning process as much as it is a gaining of range of motion process, right? And with pain, when there's pain present, sometimes just the teaching of a different way to do things without even changing the range of motion can change the pain. Mm-hmm. And then that to me is like the minimum effective dose that's necessary. And, that doesn't mean that you don't want to go deeper than that and, look at, okay, restoring joint ranges of motion. But if you can teach somebody to just even view the movement differently, then you've already started a process that, can be ongoing for someone. Like you hear the terminology of like creating sustainable change or like more permanent change. And to me, like the only sustainable change is education. Mm-hmm. Because it's always going to depend on what you're doing with your body for how your body is going to be, right? So if you do a certain program of strength work and you get stronger, but then you just stop working out, right? Like you're going to then get weaker, right? If you get more mobile with a certain program, you're going to get less mobile if you stop doing that thing. So you need to have education of how to keep your body moving in a certain direction, or how to avoid certain compensations, and a lot of people don't have that connection. Right. So education is where you would need to start with people, or if you want to make the most sustainable changes, like you have to change someone's understanding of what they're doing. All right. And the best way to do that is to start with their most meaningful complaint. Okay. Sometimes you got to separate the idea of what like a physical therapist is, though, or a movement professional is. When someone's coming in and they have pain, they might think, okay, you're going to change my structure, you're going to change my MRI somehow, and that's just, you have to explain that. It's like, I don't, maybe that happens, but I certainly don't have any direct way of doing that, and I don't think of that as my job. But what I can do is look at, what you're having trouble with, what action are you having trouble with, and I understand those actions well. That's what my education is about, and then I can deconstruct that and hopefully demonstrate to you a way that's more efficient to do that doesn't bring on pain,
right?
Or has a much less opportunity to bring on pain. When you do that, you actually put people in a position that they're uncomfortable a lot of times, right? So walking is a really good example. When you start to slow walking down and you have people try to hit positions that you want them to hit, it throws balance off. It just becomes something that's like, I can't do this. Like this isn't how I walk. I can't walk like this. And that's fine. And you have to have that conversation with somebody to say, like, okay, but like the goal here might be to change the way you walk because it hurts when you walk right now.
Mm-hmm.
Right. So like there might be a conversation there of just trying to get people to understand that you have to change how you do things physically, not have somebody change you so you don't have to change at all.
Mm-hmm.
Right? And I think that's a really important thing to see. If people are coming in with a mindset that it's not about them changing, it's about you changing something in them so that they don't have to think about changing, right? And that there's a subtlety there, but I think it becomes a huge difference in somebody's prognosis. And that ties into the idea of like locus of control. Do you feel like you're trying to, that your recovery is based on somebody else and you're just not even involved in the process? Or is your recovery based on you taking the reins and you being able to change yourself?
Mm-hmm.
Right? And there's other processes like self-efficacy and all of that. So all of this has been studied in someone's prognosis to actually get better. So people tend to do better if they feel like they do have some control over their own change. They also do better if they feel like they can change for the better, right? Which is more of what self-efficacy is. It's like that I have confidence that I can actually change myself for the better, right? So it matters, like if you have like a positive attitude, if you will.
Yeah.
Right. And that also goes into the subjective side of pain. Like, what is somebody's beliefs about pain? Like, if I have pain in my life, then something's broken in me. If that's an idea, that's a hard thing to get better.
Mm-hmm.
You know what I mean? And you may not get as much buy-in. Like, someone might not be as interested in breaking down their movement because it takes time to do that. It takes time to make change to how somebody walks. It takes time to make change to how somebody squats or whatever it might be that's bringing things on. If they have an expectation that like they're not part of the process, that it's just you that's going to change them, then they're not going to have as good of a prognosis, at least with physical therapy.
Mm-hmm.
But they may have a better prognosis with surgery because that's more of what surgery is.
Right. It's just basically someone's going to fix you, and then
right. Even if it's not a structural thing.
Yeah.
Because it creates a nervous system change that says like the threat that they think is there has been changed from a surgical standpoint.
Mm-hmm.
And that matters, right? Like that matters just as much as whether the surgery was mechanically needed or not.
Yeah.
Right? And so all those variables have to be taken into account. Like when somebody does get surgery, when like, do they need surgery? Well, you can never say they do or they don't. And it's not just based on what an MRI or an X-ray shows. It's based on the subjective beliefs of somebody and what have they already done. If they've done all of the non-invasive stuff and it just doesn't, like they haven't gotten the good results, and they seem to also have worsening beliefs about the possibility of something that's not surgery helping them, then they might be a good candidate for surgery.
Yeah.
You know what I mean? Because it does go into this, it's somebody else helping you. Like, you don't have to change. You're just getting your body changed by somebody else. And then, like, you'll just go right back to what you were before. Like, if it's not a realistic expectation, but sometimes that does give the best results. And then afterwards, you can get somebody to be in a better place to accept, like, responsibility to change themselves. Because they were so wrapped up in this idea that something needed to change within their body that they need that first before they can actually have any success with any type of movement practice.
Right. And that's like, it almost seems like the transition from going to chronic pain and then basically translating it to an injury. And then it's sort of transforming the process by getting the surgery. It kind of becomes that injury recovery instead of like trying to heal from pain. And maybe that's just the easier place to be mentally, I guess, if you've dealt with pain for so long. So
yes, so as a therapist, you have to be careful not to take a side one way or the other, because you don't know. You're not right. You're not right with either. I think you want to educate people on some of the literature about, like, what pain is and what pain isn't. So you do want to educate on the fact that there is a difference between pain and structural damage. Like, I do think that's an important thing to educate someone on. But you don't want to take a side and say, like, well, that means that surgery is not useful, because it can be very useful. It just might not be useful for the ways that is thought about, right? Like the theory behind what's happening with surgery, if it's just something needs to be fixed and that was the only problem from a pain perspective the whole time, like, that I think is a limited view. But if it starts a process over in somebody's head and it decreases the threat to the central nervous system, the autonomic nervous system, then it's a very valuable thing, right? And you're left with as a therapist, you have a better prognosis with this client now, because they're coming with different beliefs.
Right, absolutely.
And that matters. So you just have to be careful with the language that you use, like, of taking a side, like invasive, non-invasive, because in the long run, like, is it that much better to go through non-invasive work for months, years, with and just being frustrated, and not really seeing much change? Or is it better to just, do a surgery and start a new process? It's not getting you back to where you were before. Like, I think that's important to understand. Like, surgery doesn't get you back to before you had pain. It's you have a new body now. Something happened, something changed within you, right? So, but you might be starting from a better place than you were for the last several months or years. Right. But it is still an ongoing process, and that just might be a better ongoing process than it would be without the surgery. And I've had several clients that surgery was a game changer for them. But I don't know exactly why. Like, I used to think when I was a newer PT that I was like, oh, that's exactly what they needed. And, it was like, there was nothing that we could have done from a therapy standpoint until they had the surgery. And because of structure, and that might be true, but you just don't know that that's true, because there's so many other variables that are always in play when it comes to pain.
Right. And it's interesting to think about, for me, surgery from those two different perspectives of maybe if you're a long-term chronic pain client versus, like, when I had ACL surgery, when I tore it, it didn't hurt. Like, it's like I would just fall over trying to do things. and it's like
that's the other thing too. There's pain, and then there's like actual instability.
Mhm.
That's not pain, and that's where like an ACL is always like a good example of the difference, right? Because a lot of people get ACL surgeries, a lot of people have ACL injuries that are just very obvious. Like that's an obvious example of what an injury is,
Mhm.
and how it is separate from pain.
Right.
You can get pain, but it's not the same thing. So when somebody's recovering from an ACL and they have had an ACL surgery in the past, it's actually really tricky to know like what they're ready for.
Yeah.
You know, so that's where you have to have some movement norms, I think, in your head. You can't go based on pain provocation, especially for an athlete that's going to have to do higher level things. And then there's eventually just like a leap of faith where it's just like, how do you feel? You feel solid? You know what I mean? Like, so you want to be really good at breaking down movement tasks, but I think pain becomes less of the marker of control that you're looking at, and it becomes breath control, postural control, impact control when you're looking at a lot of different sport specific tasks, or even just daily life specific tasks that would have more of a challenge to knee stability. Right. And so you always have those. To me, I have those 4 markers in my head when I'm looking at movement. Is like, does it produce pain? If it does, I want to like really deconstruct that and figure out like, when does it produce pain? Does it get worse if you do more? Does it get better if you do more? You know what I mean? Like, you just really want to understand all the corners of pain, but then you also look at breath control, postural control, and impact control, and you have your different ways of looking at that. So when it becomes something that's more of a stability oriented thing, then pain isn't going to be as big of a marker to look at, but you can then focus a little bit harder on, the things that you're looking for postural control and for breath control. And when you're looking at those, your guiding principles would be, can I get things closer to the middle? Can I be working from the center out a little bit more? So with the breath, it would be like, can you get things moving, abdominally? So fill the glass from the bottom up. Can I go like low to high and then expand in all directions? But then can I also create this, compression when I'm exhaling and direct that where I want to direct it? And then with posture, it would be like, am I moving from my hips the way I want to move, and from my center the way I want to move, so that I don't move excessively from lower, the knee in this case. Those would be your guiding principles that you're always looking for. It just would be dependent on the movement for how you see those and how you assess those.
Right. And just thinking about, like, I feel like time can always be a variable, a important variable. Is like, if someone says it's like, I get pain when I'm sitting, but it's only after a certain amount of time, then how much of the treatment does just become like what, like, when do you focus on going after load management to a certain extent of like volume of sitting, trying to just move more, versus or not versus, but combining that with, again, like bringing it back to postural control, breath control, impact control, all of that?
Well, I think that's a great question. Like, if somebody is having issues with the duration of sitting, one, impact control is really not at play at that point.
Yeah.
Other than tied into postural and breath control, right? So if you can control your breathing and have more variability of breathing, then you can actually have more variability of the pressures that are being put through your body, even when you're static and sitting, which has some effect on the impact of your body into the seat, right? But a big part of that is just adjusting, having the ability to adjust your breath in different ways, and then having the ability to adjust your posture in different ways within a seated position. So you can, if you do those and have more options to do that in a sitting position, then you are changing up, you're making basically the static long duration seat more of interval training, right? Just because you're constantly able to mix it up even without having to stand up. So you need to give people more options for movement, so that they can vary up the positioning. But then the other end of that is, all right, it's just another version of building endurance, right? Pain is sort of a limiting factor. So if we would look at it from a perspective of walking a longer distance, at some point, any of us would have a point where we would start getting pain if we walked too long.
Mm-hmm.
At some point, any of us would have pain if we sat too long. It might not be in our back, but it'll be somewhere, right? And it just might be way longer than we would notice in a day-to-day activity. So people that you see in the clinic are going to have pain that comes on within their daily life, right? Like within action in their daily life. So education on just looking at it that way and saying, okay, when your pain comes on, that just is your body's way of telling you you're doing this particular thing too long.
Right.
Right. So there would always be that at some point. It's just that it's really much shorter now. So it's messing with your normal daily activities.
Mm-hmm.
And the thing is with sitting, it's like we're all sitting so long for the most part that we almost get spoiled with the fact that, okay, like I've been sitting for 8 hours, like, and I'm surprised now my back is hurting, right? Or it's like I could sit for 2 hours. Well, like 2 hours is a long time.
Yeah.
But if you need to sit 8 hours, 2 hours is nothing.
Right.
So it becomes relative to what you need to do for the longest amount of time. So we have to teach people how to make things more intermittent, more interval based. And that to me is what all the idea of changing supports and things like that. You might give someone a better position to start. And I think a better starting position is often a better position to breathe in, right? So if you have like your respiratory diaphragm stacked over your pelvic diaphragm, it's the easiest position to get the rhythm of the breath, right? To get expansion and compression with less effort.
Mm-hmm.
But outside of that, there is no optimal position. There's just moving more frequently, right? And trying to figure out a way to do that still fits into your day. So it's not feasible for people to, do yoga every 20 minutes, right? But it might be feasible to get up and do 10 back bends or do like one vinyasa, like one sun salutation every 20 minutes. So if that can be something that somebody just puts into their day from a behavioral standpoint, then you see, did that make a difference with your pain? Right? Like there's always that assessment. And I think a change in someone's pain provocation is the best assessment you can have as a physical therapist, right? Much better than looking at anything visually, like a change in posture, like static posture, a change in even range of motion. Because I think range of motion is dependent on a lot of things too. Like if you've been sitting for several hours and then now you test somebody's range of motion, it's going to be unlikely to be at their best at that point.
Yeah.
Right. But as you start to see people for longer, then you can start to see change even, after they're cold or something like that. But it's not going to be as meaningful as seeing that the thing that they were complaining about is getting better, right? Like they're complaining about sitting. You've made it as objective as possible. Said, okay, it hurts when you sit, for 2 hours? Now, okay, you can sit for 2 hours and it doesn't hurt, but it hurts at like 2.5 hours. Well, you've made a change, but they still have that pain, right? Mm-hmm. And a lot of times the intensity of the pain is the same when somebody has the pain, but they're just able to tolerate the action for a longer period of time. Yeah. And that's important to understand too, and also educate your person on that. Like the goal isn't to eliminate any opportunity for you to ever have pain in your life, because that's not possible. Mm-hmm. It's just to try to get you to progressively be able to do more compared to what you were able to do when you come in.
Right.
And oftentimes when pain starts, when there was no like trauma, there was no precipitating factor, it was sort of like this insidious gradual onset. Like you can assume that something needs to change. Like this was building over time, and it's going to be very, very hard to get back to where you were without pain, without changing something in your behavior.
Right.
right? Because there was something within your behavior most likely that was bringing it on. And that's not a judgment. So like when you bring that up to people, sometimes it can sound like a judgment. It's just like, no, it's just like that's gonna happen. Like depending on the actions that you're doing, there would be a point where it would be too much for your body, and you don't really know when that is until pain comes on.
Yeah.
So having some pain and being able to use that as an indicator of, oh, I need to change something is really valuable. So education on the fact that to use pain as an indicator of change is super valuable. And like getting out of the mindset that it's an indicator of damage is really important, because if you have pain and you're immediately like, oh, what's wrong with me? Like, all right, now I got an MRI, I got an X-ray, and then you go down this cycle of saying, okay, well, I have this. Like I'm identified now as a person who has a herniated disc or has arthritis. You've just changed your whole thought process about how something can get better, how to use this symptom. It's no longer a valuable thing. It's just something to be completely avoided because it's just part of this chronic condition that can't be changed. And it's dangerous, right? That leads to chronicity. It takes something that's just acute and just, oh, I just need to scoot my butt and it goes away. If I can notice it quick enough, like, and have it identified as, okay, this is telling me I need to change my body posture. If you can get right on top of the onset of the symptom and just adjust on a regular basis, then it never has to be more than just an indicator that your body's telling you to change something. But when it turns into a disease, it gets worse and worse a lot of times.
Right. Yeah. And then that might be sort of where it becomes, the mentality of thinking someone, like locus of control, thinking someone needs to change you rather than you can. So then you talked about this a little bit earlier, but when with clients do you sort of work in, or as you said, poke the bear? Like when do you poke the bear versus when do you avoid it completely or avoid it more so? And I feel like what I hear you saying is, it depends if it's acute or chronic, depending on how much you go into it. But if you could just talk more about that, I'm curious.
Yeah. So I would say if it's like within the first couple weeks of an injury, I'm going to be very cautious. And if somebody's got pain at rest, like that's my indicator, right? It's not when you ask them what brings it on, and it's just like, I have it all the time. Like it hurts right now. It doesn't matter what position I'm in. That connected to it being a new pain is something that I often refer people to get medicine at that point. It's just like if you want your pain to be decreased, medicine will do a lot better than I will do for you.
Yeah.
Typically in those places. Now, if that comes on and it's not a new pain, or like there was no trauma that would precipitate that, there was no mechanism that they can really think of, and they're having just pain at night, pain that's constant, you might also refer out for something more sinister, like a red flag or something like that. All right. So those two can sometimes go hand in hand, but I think the duration and then like if they can tell you like, oh, I felt it when I was standing up, and that's when I noticed the onset of it. And now it's just be like, I can barely move. I can barely get out of bed. In the last couple of days, medicine is usually a really good option. Some type of, anti-inflammatory, strong anti-inflammatory. That's the time to use it. And there's a lot of people now that are just really afraid of medicine. And I think that's because they just, like as a therapist, you understand the difference between acute and chronic, but the general population doesn't. They're just like, they just hear things like, oh, okay, like corticosteroids will destroy my bones, destroy my tissue. And that can be true when they're being taken for chronic conditions. But maybe that's like the only option, like for some chronic conditions, right? It's like it's better than if you weren't taking them, but you do get side effects that just keep coming if you're taking more of it. So, and when it's acute, it just, you don't really have to be as worried about that.
Right.
Right. But I don't think a lot of people understand the difference, right? They just think of it as like, this is poison. as
Right.
opposed to it having something to do with the dosage and how often you're taking it.
Hmm.
Right. So, yeah, I think medicine is awesome for acute things.
Yeah.
You know what I mean? It's just, if I had some of these symptoms that people have, like the real aggressive nerve pain down the leg, I would go right to get a cortisone injection, like, or an
Yeah.
epidural. Like, that would be the first thing I would. I mean, I would talk to the doctor, but that would be what I'd likely want to do first, because I haven't had much success with being able to move people in a way that decreases their pain in any substantial way. And I've seen people get substantially better with a good, like, one injection. That's
Hmm.
just, it was a game changer for their recovery, because now they can actually do things from a
Right.
movement standpoint that gets them back into the game. If you're out of the game longer and you have to avoid because pain isn't allowing you to do anything, it's your prognosis gets worse and worse the longer that goes on for.
Hmm.
Right? So if medicine can get you back to function as quick as possible, then your prognosis gets better.
Right.
And you're not changing anything structurally necessarily. You're just desensitizing the issue.
Hmm. And then sometimes it's just like you said, like you just need to get that pain to subside so that you can even do anything with them, because
Exactly.
otherwise anything could bring it on, I guess.
Right. And so, in those cases, not so much, but in general, when people have like sensitive pain issues that maybe are a little bit more chronic, it's really important to show them what they still can do.
Hmm.
Right? And this is where I think a lot of clinical physical therapy fails, or at least has in the past, and I think it's getting a little bit better with it. Is we were so focused on what the diagnosis was from the physician, or what the ICD-9, ICD-10 code is, that you're just focusing on what they can't do, right? Like, you're trying to get them a range of motion back. You're trying to get them to be strong in the area that's painful or weak. You're trying to get them to just do more with the area that hurts, instead of really conditioning them distant from the area of pain or area of dysfunction, and just getting them staying in the game, right?
Yeah.
So, like, think of it like an 80-20 rule of, fitness to rehab, right? 80% should be what you still can do. And this doesn't necessarily have to be in a clinic, but if you are working with somebody and you have the means to be able to train them in a matter that is distant from their injury, and then maybe spend about 20% of your time actually working on their limitations, then you do that over time. A lot of times the limitations will be able to get better quicker, because you're not irritating them.
Hmm.
But you're also that you can only do so much with limited areas, and it often becomes this, like, home exercises work better than what you're doing with someone in the moment, oftentimes, like right around the sensitive area. So if you do short bouts frequently, as opposed to a long bout on an area that's sensitive, you'll likely have better results, because you don't want to do anything that's too long on an area that's sensitive. All right. But it does need the work. So teaching people to just gradually throughout every day, just work on this area that needs work, that doesn't need to take a lot of time. But I think what takes more time, or what can take more time, is really trying to give somebody a nice fitness routine around their injury.
Hmm.
And, if you have a general person coming in that doesn't have a fitness background, it's an opportunity for them to work with a professional
Right.
to actually get them more out of their body. Right. So to separate out injury from, like, just more optimal movement in the body, more movement options, is really harmful in my eyes, just because it's a waste of an opportunity. You can think of it that way.
Hmm.
Right? Like, you have this opportunity to say, like, you can come in now, you can exercise, like, we can get you in condition in a way that we know is good for your overall health in many other ways. And that would be, to me, it makes a lot of sense, that would be valuable for the thing that's injured, if we just look at the body as a system of systems, right? Like, or how do we promote healing? Well, we get things moving, right? Like we get fluids moving through the body. We can say increase circulation, increase lymphatic flow. All of these things is just, we want movement.
Yeah.
And we just don't want to irritate something that's sensitive.
Mm-hmm.
But that should be a big part of our job, is to know how to do that really well, right?
Yeah.
To move somebody in as close to optimal as possible without pissing the thing off that they're there for.
Yeah.
Right. And I just that wasn't a part of my schooling. And it's really only therapists that have an education in strength and conditioning that are good at that, from my experience. And maybe schooling is a bit different now, but when I got out of school, and just the people that I met that were good at looking at things like that, they also had their CSCS. They also trained clients, and they always had the fitness side of things too. And that's where combining the two, it just becomes, after a while, it's like they're not separate things. They're just part of this continuum, and pain fits into that continuum, where it's like, okay, this is part of what they can't control right now, and I just have to understand that. So I have to have whatever they want to do that's close to their pain. I just have to make that be really regressed, so that it doesn't provoke their pain, or it provokes it exactly in the way that I want, and is healthy for them.
Mm-hmm. Right. It's I just think I feel like that's becoming more and more a realization, is just that PT or physical therapy and fitness are really the same thing, just different places along the spectrum,
right,
than maybe it used to be. But I'm growing up now, so I don't know what it used to be like either. So.
Right. And your confidence around pain is really important. So if you are like a strength and conditioning professional, like, you're not trying to treat someone's pain, but if you're really comfortable working with people that have had pain and working around that, you're sometimes doing more for people that are in pain than a therapist that is just working on the area of pain.
Mm-hmm.
And if you really have good relationships with your clients, what you start to see is that, these pain presentations, they come and go, as long as, the body keeps moving. Yeah. And you have enough education about what to do with your body in that short acute time frame where you have some type of flare up, or where you have some type of exacerbation. It becomes much harder for something to turn chronic if you're in the throes of training and keeping your body active.
Right.
And so if you are working with a trainer, even if that trainer is not a physical therapist, but you really trust your trainer, and that trainer really knows how to work around symptoms, just the act of not having to take 2 weeks off from training because you're in pain, but really being able to come in and have that session be modified so movement can still occur in a pain-free way. You're staying in the game. Like, people get better quicker. Like, they don't need specific therapy a lot of times. They just need to not be, they need to not overprotect, and then they need to not be irritating things. And there's that middle path, which could be difficult. And that's where I think physical therapists should be the best at that. But some trainers are really good at that too, just because they have a lot of experience.
Well, and then for trainers, when does it, like, at what point, if you're a trainer, do you refer out to a physical therapist? Like, when do you work with pain directly or not work with it directly, but just like modify things for clients? And when does it get to the point where it's like, okay, like, we'll keep modifying things, but maybe you need to go see someone for this, whatever, something that's causing an issue for you?
Well, I think it depends on your relationship with the therapist. If you're a trainer, right? Like, if you feel like, if I send this person to the therapist and I don't have a relationship with this therapist, and I might not be able to keep working with them, I would delay that quite a bit, actually. As long as, you're not trying to work on, as long as things aren't getting worse, but that you're able to keep people moving. Like, I wouldn't want to stop that momentum. But this is why it's important to have good relationships with a therapist. If you have a relationship with a therapist and they respect what you do, and there is this understanding that it'll be like a shared treatment basically, or shared collaboration, then you do that right away. Just say like, all right, why not go, see my friend who knows a lot more about how to deal with your pain, or at least how to talk to you about your pain than I do. But we usually collaborate together, and that doesn't mean you have to stop with me, but maybe you can do a little bit of both. Or if you're seeing someone like twice a week, see him once a week, see me once a week, and just knowing that you'd be on the same page with that. If the therapist thinks a little differently and you have that good relationship, then you would trust that, okay, that would be the time to maybe spend a little time away. But I don't see many reasons. Like if my friends that are trainers, if they're referring to me, I take that as like, okay, I definitely want to make sure that I'm doing everything I can so that they still are able to see that person that just referred them to me for many reasons. One, from a professional collaboration reason, like I don't want them to feel like I'm taking their people or taking their business away. But I also think it is the best thing for that patient to not have them come out of their routine of fitness too much. And just say, okay, like, can I just give you a couple things, maybe from an education standpoint, that would allow you to just stay in the game with what you're doing from a training perspective? And then I also have the communication with the trainer and just say, like, yeah, this is what I'm seeing. This is what I'm giving the person to be able to get better with. This is the stuff you might want to be careful with and just, not do or work around. But to me, it's like you really want that to stay, like in the same, or you want to be working together as much as possible. You don't want to separate it for too long.
And I feel like the importance of, as you said, staying in the game, like can't be understated, because it's just, I feel like getting deconditioned could just be detrimental in different ways.
Yeah, it's deconditioning, and it just also, you don't want to be a patient if you can help it.
Yeah.
Right? Like you just want to be getting help from somebody that has more knowledge about injury, about it, like that not just has more knowledge from a schooling standpoint, but just from an experience standpoint. That like a big part of what a physical therapist's job is that they are seeing pain all the time and they're knowing how to work around it, because they're always testing out like how some intervention, how some movement affects somebody's pain, where that's really not what a trainer should be doing on a regular basis, right? Like they're not seeing like how this movement affects your pain, because the people that they're seeing aren't in pain all the time. Right? So if that is the understanding of the separation and what the specialty is from the therapist, just like you don't have to feel like you're an actual patient getting physical therapy. You're just getting consultation from somebody who understands that stuff better, so that you can get more out of what you're doing with your trainer.
Right.
And so that the trainer who doesn't get that experience, but has experience in things that the therapist doesn't have, can now add to their knowledge base to better help that client.
Right. Makes sense.
But I think it is important not to just feel like, oh, well, now I'm injured, and when I'm done being injured, then I can get back to doing what I'm doing. Like that should, I don't think that needs to happen.
Right. Absolutely. I guess the last big one I had is just, how I've thought about this and tried to read about this a little bit, but like, how does mindfulness and mindfulness practice relate to pain and pain symptoms? And how can it be beneficial for people? And do you ever sort of go to that as part of the education piece for someone in pain?
Yes. I think there's mindfulness is a really broad term, just like exercise.
Yeah.
So there's a couple different ways to look at it. One, like mindfulness is a fundamental of how to deal with like anything. All right. And I kind of equate it to proprioception sometimes, like position sense, where it's like once you have a position sense of certain activities, like it's automatic. You don't have to consciously think about the idea of proprioception anymore.
Mm-hmm.
right? But you sometimes have to train things like proprioceptive exercise to get your position sense better. So when you train mindfulness, you with you become more automatic at being mindful of different things that otherwise would just be automatic, like habits that would be maybe harmful, or you would have a different way of viewing a certain issue that is less accurate than actually being present and mindful would be. So when it comes to pain, there are all of these thought processes that might come or be tied into pain that are sort of static in nature or permanent in nature. And when you are someone who practices mindfulness, or you get more into practicing mindfulness, what you look at is like there is nothing that is permanent or static in nature. It is like things are constantly changing. So even a pain that's happening in the moment, if you are able to be with that pain for a little bit and not judge it, but just literally be like mindful of it in the moment, you see it change. Mm-hmm. And then that ability to do that, and having a practice of doing that with any sensation on a regular basis, starts to just change its very nature. And it's a hard thing to describe in words, but it becomes very obvious from a feeling standpoint, but it goes way beyond pain, right? So like, I think there's this practice of mindfulness that just makes everything easier to deal with. Mm-hmm. Because you see some of the illusory nature of our thoughts and the way, or like our stories that we tell. And, mm-hmm. and pain is like, really, really tied into that, right? Where there is the physical sensation of it, but most of the time that is not what disables people. It's not the actual physical sensation. It is the story of, well, I have a damage inside my body. This is going to limit me from the things I want to do, right? It's not about the presence of the physical sensation of pain. It's all the other issues that will come from this pain that we're already thinking about in the future, or again, it's the past, the history of what we've already had with the pain. Mm-hmm. So we're not being mindful of the actual physical sensation. Oftentimes, we're being taken away by the stories of the present and the past, or mm-hmm. the future and the past. Mm-hmm. So having that practice can allow us to just have a totally different relationship to pain. Yeah. And what we were talking about before is that we need to use pain as like an assessment for us. So it is very valuable. If we can have this present moment awareness and mindfulness of pain, then we can view it as, this is my body telling me that I should change something right now. And that's it. Like, it doesn't have to be scarier than that. Mm-hmm. Sometimes there's just like, okay, I just have to, like, I know I'm getting pain because I haven't changed my position in the last 2 hours. I need to change position. If I can't change my position, the pain's getting worse, well, at least I know that there's a relationship to that. It's just like, so as soon as I'm able to change positions, I will now go do something that is separate from that, and then I'll be mindful of how that changes my symptoms. Mm-hmm. Right? And something like a diagnosis that is static doesn't allow us to use pain and be mindful of pain. It just becomes this, it just becomes this static thing where, like, it doesn't even matter what you think. It's just, this is what my doctor's telling me is wrong with me. So there is no value then from a diagnosis perspective to being mindful. And that, I think, is nonsense. So what you start to see with the mindfulness of pain is that you can be very specific with pain. You can see it change, and it becomes a totally different thing. And that can make it much easier to deal with. Right. But it can also give you more information about what actually makes it better and what actually makes it worse.
Mm-hmm. Absolutely. Cool.
So then there was like another part of that I was going to use. But just the other part of thinking about spending time in discomfort and having a practice where you do that. So let's just not think about pain, because that can start to elicit, certain health things that might be dangerous. But let's just focus on some other things that we know aren't dangerous that we do on a regular basis that are uncomfortable. So exercise becomes one of those, right?
Mm-hmm.
You train yourself to tolerate discomfort so that your body can do more things before it feels that discomfort, right? That's a lot of times what training is. So if you're getting to a point where you're doing a certain amount of repetitions, if you're like don't have to work at all, then you know that you're way stronger than that effort that you're doing. So you would have to take yourself into a greater challenge so that you find some type of discomfort. That's always what we're looking to do with training. How much discomfort would be dictated by like what our intention is.
Mm-hmm.
Right? So like hypertrophy style training, we tend to find more discomfort versus something that would be like just doing aerobic exercise where the intention is not to really get faster, but I'm just going to try to move for longer. But the discomfort might come from the longer, like how long you do that. So if something is really easy at first, but you do it for longer, then it eventually becomes uncomfortable. And you're always trying to find that onset of the comfort that is tolerable, that you're in control of. So that there's a training to that. Well, the same thing can come with just being still with discomfort. And if you find a certain tolerance point that you can be with, that can actually improve over time. So you can also get a sense of when it's just like this is not helpful, right? Just by being mindful with something. So say you're sitting and you have a back pain with sitting after a certain amount of time. And we already talked about this example, but let's just look at like sitting meditation or mindfulness meditation in a sitting position. You, instead of sitting at a computer, if you're sitting and being really, really mindful of your pain, that might be something that is the most direct way to see your pain tolerance or your sitting tolerance improve over time. Right? As opposed to trying to do it while you're doing many other things and then also not really exploring the nature of that pain. Now you really can dive deep into building like your sitting tolerance just by having a mindfulness practice in sitting, right? So you can use your mindfulness to actually improve your positional tolerance. Right? And that's sometimes tied into breath control. But it goes beyond that. So it's not a specific mechanical change idea. It's sort of a noticing. And sometimes with that noticing comes insight into, oh, okay, this if I breathe this way, it hurts less. Mm-hmm. Or if I just let go of certain guarding and tension, it hurts less. But it becomes very personal, right? It's not, I don't think I can give people specific cueing that's going to guarantee that their pain is less. It's got to be a practice that they feel comfortable with. Otherwise, it doesn't decrease the threat, which is ultimately what pain is.
Right. And then that again comes back to the locus of control idea.
Right. Absolutely. So mindfulness to me in my life has become this ultimate practice of feeling like I have control of things that I didn't think you could have control of. Mm-hmm. And I think the more you dive into that, you realize like we have more control than we think, but we have to almost like let it come and give yourself some space from the external actions as opposed to trying to attack it and fix it. It's mm-hmm. more just like, just be with it and watch it change. And then it wasn't what you thought it was in the first place. Yeah. So there's sort of like this illusory nature of pain that, it's hard to say that when you're in chronic pain, right? And it's like, I certainly wouldn't want to judge anyone's pain, but the practice of mindfulness allows you to see I guess, a more accurate reality. Mm-hmm. And sometimes that is like, well, there's nothing I can do. I just can't sit any longer. But you at least get a deeper understanding of the nature of your pain.
Awesome. Cool.
But I think that this is a very important conversation, and it's not super objective. You know what I mean? Like there's not a really step-by-step checklist type of way to work with people's symptoms. The best I've come up with in my experience is to, put it into this type of movement continuum idea, which is pain is just one marker of control of movement. But it also is the priority, I would say, if pain is present, right? That you would use that as the thing that would tell you what somebody's ready for more than anything else.
Yeah.
And it's valuable, and it's something that shouldn't be avoided, but it needs to be respected.
Absolutely. Yep.
Cool.
Awesome. Thank you, Chris.
Absolutely. And then I know you got some other questions, but we'll pick up on them maybe midweek, maybe just next week.
Okay. Sounds good. What's going on with my straight leg raise and toe touch the squat?
Well, obviously your toe touch is good. So you get your nutated in the sacrum, right?
Yep.
And you can't counter nutate.
Nope.
The straight leg raise looks limited, which means I'm straight leg raise is one of those things that I still need a little bit more understanding about how to view that in the realm of all of this compression expansion stuff.
Yeah.
But you look like you're somewhere maybe in the 70-degree range.
Okay.
It looks like with both of those.
All right.
And I would have to look a little bit. I'm going to look at the video and see a little bit more specifically where you land there.
Yeah.
But so you still think of it as the 0 to 60 would be in that, exhalation or that inhalation range.
Yep.
And then, 70 to 90 or a little bit past 90 is going to be where you have enough internal rotation to get there.
Yeah.
But with all the other things that we've seen, we know you're limited with both, but you seem to be more limited with IR than you are with ER in the hips.
Yep.
So, I think for what because I was just looking at the rest of the stuff that we did earlier today as I was putting the video together. And that's why you just need a general program
yeah.
for everything, but just with the understanding and the education of all this expansion and compression. So bringing your body closer and closer to these compressive positions and using breathing to get more and more out of them, I think is valuable for you, right? So you would also do well with loaded mobility, which is what squatting with like a goblet squat is loaded mobility, right? Because you need that load to get yourself in or closer to those positions of compression that you can't get to. And then you need to have enough support from the load as a counterbalance to be able to spend time there, one, and then be able to breathe in the time that you're spending there in a manner that gives you space.
Yep.
Right. So I don't know that we need to be super specific. Now, when I looked at your standing posture,
yeah,
and it's the posterior view, I think, was the most obvious of where you're limited, at least statically.
Yeah.
That your head is being shoved forward on the backside, and there's a ton of compression up in the dorsal rostral, but you do have your head being shoved forward there. And you see that the left side is starting in more IR than the right, where it's just you're more forward there. But we saw that with your range of motion movements too.
Yeah.
So it's, to me, the static standing posture is just more of a confirmation of what you find with your movements, because the movements will be more important, right? How you're standing is just going to be maybe something that's valuable, maybe not. But if somebody just tells you stand differently and you can do that pretty easily, then I don't think your resting standing posture gives a lot of information.
Makes sense.
But it confirms some of the things that we've seen with the movements.
Yeah. Well, I just found it interesting to see it, especially from the posterior aspect, where I feel like you can somewhat clearly just see compression.
Yeah, absolutely. And I think it is important to see the back of yourself. a lot. Like I know I'll spend too much time looking in the mirror sometimes when I'm like trying to see the backside of my body and then trying to also connect it to different shoulder motions.
Yeah.
And what I have an image of in my head is just not accurate to what's actually happening when I look in the mirror of, you know, scapular position and things like that. So that's valuable. But again, you're doing that more dynamically by moving your shoulders into different positions and then being able to connect, oh, look at what's happening with my scapular, or look what's happening with my head as soon as I move my shoulder into a certain position. It is helpful to be able to see, you know, different angles of your body that you usually don't see. So I think the posterior aspect, like we can never see that.
Yeah.
And we always can see like the front of ourselves in the mirror or even like the side here, but to really be able to connect like, oh, okay, look at my head in relationship to the upper back, and then having the education that you're getting now of what that actually means is valuable.
Yeah. Cool. Yeah.
How's your gymnastic stuff coming along?
It's going. I'd slow progress for sure, but I mean, it's getting just like slightly more comfortable to be in some of the positions, but yeah. So yeah, I like it though. Like I feel like I'm learning things.
So here's another discussion about pain, right? So you are feeling that discomfort because we're trying to get you into positions that like you can't get to, right?
Yeah.
And for someone else, that might actually be like, you're hurting me.
Mm-hmm.
So that's not a good routine, right? And that goes into your decision-making process as a clinician to what interventions would be best for someone. I wouldn't throw many of my clients into like a general gymnastics mobility routine.
Yeah.
But I would do that for somebody who's got like bilateral tightness, and you can call it compression, anterior, posterior compression. That's how you present. But you also have like a history of athletics, and like you know what discomfort feels like.
Yeah.
And you know the difference between, you know, something that might be safe and something that might be unsafe. But you have a higher tolerance for exploration of discomfort.
Mm-hmm.
That's the way I put it, because I don't think it is like good pain and bad pain. I don't think that exists. I think it is just to like a willingness to explore discomfort, and then also have a sense of like you're feeling your own body enough to see if you can make change to those feelings, instead of just like, again, being mindless and just saying, well, I did the exercises. Yeah. I didn't think for a second. I didn't pay any attention to what my body was feeling. I just did what they told me to do in the video. Mm-hmm. Right? So there's a big difference there, and pain plays a big role in that. So you have to take that into account with any client when you give them any activity. Is like, do they give a shit about paying attention to their body? And if they don't, then you should not give them complex things. Yeah. You have to teach them to kind of give a shit about what they're feeling before they can do things that would be harder to be able to control, or where it's really necessary to actually feel what you're feeling to get the most out of things. So as you're feeling this discomfort, you're basically just going to try to adapt your body to get deeper and deeper into these positions, but you'll likely always feel a discomfort somewhere that's similar to what you're feeling now. Yeah. Right? It's just, it'll be deeper, into the game. Yep. But that's pain there too, right? That there's no real difference between that pain that's just, okay, that's an uncomfortable like position for you, than actually like what you would think of as an orthopedic injury type of pain. Mm-hmm. Okay, because either way, it's just like, what can someone tolerate, and that is very specific to each person.
Right. Yep. For sure.